is the special meeting that was requested by members of the Health Council. We are limited specifically to the items associated with the special agenda. And so I want to make sure that people understand that we are limited in the scope of what we can talk about. So we need to stay focused on those items that were on the agenda. And the first item on the agenda has to do with the roles and responsibilities of the Health Council. And I've asked our representative from the Attorney General's office to provide a brief overview in terms of what our roles and responsibilities are as a health council, as members, and with regard to issues like pandemics, if she can expound on that. Tara, would you be willing to provide us a brief overview?
Yeah, this is Tara Bredner. I'm the Assistant Attorney General assigned to the North Dakota Department of Health as its General Counsel. So at the last meeting, I gave you an overview of all of the kind of statutory requirements that outline the roles and responsibilities of the Health Council. If you refer back to that statute, the majority of the Health Council's requirements or their obligations relate to the implementation of administrative rules that reflect how the Department of Health will operate. So you've seen this in function, and that anytime the Department of Health is trying to create rules, you go forward and you're the approving body that approves of those rules before they go out for open public comment. And one of the other things that I think has come up in the recent days is the section of law that essentially states that the Health Council can direct the state health officer to do or implement anything that it has the authority to do by law. The one thing I would note about that is I have never seen that used. And so if, as this body kind of considers all of the things that are happening today, I want to make sure that we're in a place where we're not putting the Department of Health in a position that's going to essentially cause individual employees to make a decision as to whether or not they're going to follow the directive of the governor or whether or not they're going to follow the directive of the Health Council. So I think we need to kind of, if the Health Council wants to exercise its authority under that statute, I think we need to be very precise in how we choose to move forward with that decision. And that's why I'm here today, is to make sure that I walk you through how we make that happen if that's the route that we go down. And then I would just say, if there are any questions about the roles and responsibilities of the health department and the Health Council, if you have any questions, I'm happy to answer them.
Thank you, Tara. Are there any questions from members of the Health Council regarding Tara's direction?
Mr. Chair, this is Kristen.
Yes.
Tara, I guess one thing that I have a question of, and I don't know for sure if you're the right person to answer this, but I think I've always struggled with, I understand statutorily what our scope is, but since we haven't been used in that way, kind of how do we get from where we have been to kind of practicing up to the top of the scope, as it were, as a council? So even just like, what's the practical application of how do we kind of take back some of the power that probably should have been within our group all along?
Yeah, I think that's a really good question. And I think some of that is going to come down to kind of the needs of the Department of Health as it kind of goes through the pandemic. Because, you know, one of the things that I would say is kind of advising the Department of Health through the COVID-19 pandemic has really shown the need for them to take actions and to take actions rather quickly. And so it does become somewhat problematic when if the council is looking to meet and kind of make sure that it's saying yes or no to some of these ideas. I don't know conceivably how you can schedule and get a meeting on the books to kind of provide them direction for some of these low level questions, if that makes sense. Maybe the answer is you have meetings more frequently and provide kind of just a general direction of where you want to go. as far as the pandemic, or maybe at some point in time, we need to touch base to make sure that this council is on the same page as the entities that are responding to the pandemic.
Any other questions for Tara?
Mr. Chairman, if I could ask a question, this is Daryl. Unless the council itself hasn't been involved, has the council been reached out to at all to provide any input in what actions are being taken and what the department is doing or what the governor's office is doing? Because if we haven't been, I just think we've been remiss as a council when you look at our statutory requirements. So I guess I'm curious if there's been any reaching out.
Councilmember Birch, this is Dwayne. As chair of the Health Council, I reached out in, I believe it was late March or early April, to the governor's office and told him that we are available as a tool to help maybe address some issues that the governor's office thought maybe needed to be addressed by a different means or other items. I've reached out on several other occasions since then. However, there's not really been any response or engagement from the other direction towards the Health Council. And that could just be that part of the history of the Health Council has been relatively subdued in the past. It could also be that maybe in that context that Tara provided, that role of being of having slightly higher authority than that has been exercised in the past by the Health Council, maybe is thought of more as upper level strategic direction, and then letting sort of the meat and potatoes of delivery and those things that need to be highly responsive be handled by staff and at the executive and administrative levels.
Maybe as a follow-up then, certainly we wouldn't want to put the health department in a compromising position if we would give different direction than they might be getting from the governor's office or whoever, as Tara mentioned earlier. I just have a feel, though, or a sense that we're not necessarily providing the public input that we could that's non-politicized and non-polarized in how this is being responded to. And maybe that's not needed, but I appreciate the fact that we're having this meeting now, and so that we can all get a sense of what we should or shouldn't be doing or can be doing differently.
I appreciate that perspective, and I think that maybe there is still a role for us. And given the makeup of this council, the breadth of agencies or institutions involved, from facilities to long-term care to medical practitioners that make up this particular body, that I know that the governor's office probably is getting a fair number of letters and advice from different people. But I think very much so in that context that maybe one of the things we look at from this body is providing our views or our suggestions to the governor's office through Dirk or the state health officer at the conclusion of this meeting or another meeting if we need to.
This is Jim. I have a comment. Can you hear me okay?
Go ahead, Jim.
Okay. I have the feeling that the role of the State Health Council has drifted away from what its original, the original intent for the State Health Council actually was. And I'm sure there are many reasons for this. I'm wondering when these roles were defined for the State Health Council, I've got a feeling it's probably a long time ago, and maybe it isn't relevant today. Maybe we need to maybe somebody needs to reevaluate the role of the State Health Council. I myself feel that I don't have much more basis for suggesting to the governor than the general public does, because I get just as much information, more from the newspapers than I do from the governor's office. In fact, there's been really, as you pointed out, nothing from the governor's office recently.
Thank think you might be on mute, Nguyen.
Sorry. I'm trying to be polite and mute myself, and then I forget to unmute. So I think that's one of the items that's on the agenda as number 6, and that's the North Dakota Department of Health and Communications with the State Health Council. And included in that, since the state health officer is a cabinet level member, I think that would also include how we communicate then with the governor's office as well. I think that is very much an item that should probably be discussed under that item. Any other questions for Tara or comments with regard to our roles and responsibilities, and even thought as to where we head today?
Well, Mr. Chairman, this is Tyler Lanoy, and so I'm one of the members of the Health Council. I have not been active in this council since I've been appointed. And quite frankly, one of the reasons I haven't been active is I do sit on other boards and I do practice daily, and I wasn't really sure what the role of the Health Council was, looking at agenda items and trying to determine what our real purpose was. Other than in regards to, I can look at the statute and read it, but that did not seem to identify what the Health Council was actually doing. So I think that was a little bit of the reason why I wasn't active, because it's not like the Board of Pharmacy or other councils that I've been on, when I don't really know what the expectation of the state is from us, because it's not matching what it says on the books. Now, is it completely out of line just to ask the state health department and to ask the governor's office what is their expectation of this board? Or of this council, I should say.
I think that's an appropriate question. I know Dirk is on the line. Is there a representative from the governor's office on the line? I sent out an invitation to them through one of the governor's staff.
Yeah, I'm not aware of whether the governor's office is on the line or not. As far as the Department of Health, I would say is I've been with the Department of Health for 13 years. And so my only experience has been with the State Health Council operated, which is kind of overseeing the administrative rules, handling the loan repayment activities, giving advice on topics that as we move up to legislative session, we kind of present that to you. You provide feedback, but at no point have you really directed us to do anything. And so that is where the area for me is a little concerning, that shift would happen, and so happen so abruptly. So that's where I think we would have concern as a Department of Health when we're being asked to respond swiftly, and that might not be in alignment with what the statute is saying. So there's a bit of confusion there on my end on where the State Health Council's role and responsibility is in practice to what it might be in statute.
Yeah, and thank you, Dirk. And I don't by any means mean that it's our role to direct anything that you guys do, but especially lately with all the changes that we've seen with the current pandemic. It's just interesting to me that so many changes come out so frequently that haven't even been introduced to us to even give a possibility of feedback. Whether it be new instantaneous quarantine laws or new recommendations for testing, it's just odd to me to not know that that there's actually discussion on those decisions happening, I guess. I just assume that a council of this nature would be providing input on those things before they happened on a statewide level. That's typically how councils work, where we provide feedback on important things like that. And I've yet to see that on an agenda item, which has been probably my lack of participation. So I was excited to see this agenda where it looked like I was actually going to get a better understanding, but that's just my personal perspective, I guess, and what I've seen on other councils and boards that I've served on.
Thank you, Tyler. Thank you, Dirk. I think there's a pragmatic issue there as well, in that as a board that has to schedule meetings in advance and the processes that we go through, we might not be reactive enough to actually do anything realistic in the engagement with the state health department before they have to act on something. However, I do think there's still a place there for reporting back, still getting opinion, especially looking where there's time to look forward from an information perspective. And then I also think that the members of this council should exercise and have the ability to communicate directly with Dirk and others, and not just in the purview of your seat on the council when we're looking at agenda items. I think Dirk would echo that.
Yeah, I would agree with that. And I know, I guess I was going to save it for the communication aspect, but the reality is this council has met, or in experience has met on sort of a quarterly or semi-annually basis. And when you're responding in a pandemic, that probably is not realistic to respond that quickly. Also, this is an open meeting, and when we're talking about COVID, all that information is a disease control record, which is confidential, so you have to navigate those waters as well. But that doesn't mean that any of you as individuals, as doctors, as pharmacists, as leaders in your community can't reach out to us, provide input, provide instruction, provide opinions that we would greatly value and accept at any point outside of these council kind of walls, because you're all leaders in your community, and obviously we're going to take your opinions with a high level of esteem and move those forward.
This is Jim again. I think another reason why we need to clarify the role of the State Health Council is because of communications such as we've gotten from Senator Mathern and from Dr. McDonough, to have expectations of the board that we may not have of ourselves. So that's one more thing we have to make it clear to the people who are watching us that what our role actually is.
Right, and when I reviewed Senator Mathern's letter that discussed kind of the roles and responsibilities, a lot of the items that he highlighted when he was discussing the statutory authority for the Health Council was the authority of the Health Council to make rules and regulations that impact the way things are done. And I think one of the other things that is problematic with regards to the pandemic is we all know that the rulemaking process is a 6 to 9 month process. And so that is just not it. I don't know how that the council can go through the emergency rule or the rulemaking process to make changes to the statute to, I don't know, do things other than how they're being done now without going through a significant undertaking. I mean, the second option would be the emergency rulemaking process, but that process is kind of, in order to go through that process, you have to have the blessing of the governor's office. And so I don't, to the extent that that is contrary to the governor's position, I don't know that it will be successful.
That's a good point, and that gets back to the practicality or pragmatism of this board and the role that we some might want to serve as opposed to what I think we can practically serve. And I think that what I would like to see from this meeting is a very clear understanding of sort of the updates that are there, the overall strategy that's being implemented by the health department and the state as a whole, and how the various elements that we've identified inform those strategies and improve the condition of public health as a result of informing and implementing those strategies. And as a broad group of various experts, do we have suggestions or other ways of addressing some of these issues that we would bring forward, or that we could elicit from staff in better understanding the portfolio that's available to address this from the public health perspective, which is not just monitor and take care of the patient. It's also to intercede and put a stop to further infection, a stop to further loss of life, a stop to further cost to individuals on both social and economic levels from healthcare needs.
Advice to you at the outset of this meeting is to take the information that the State Department of Health is providing you today, and understand its overview or kind of its strategic plan of how to address the pandemic, and perhaps that's different, or it has suggestions on how to improve that plan, and then we determine the most accurate way to move forward before we get to a point where we're directing specific actions and get into a legal dispute as to who ultimately has the authority to control the health department.
Yeah, you said that a lot better than I did. All right. With regard to roles and responsibilities, are there any other questions, clarifications, thoughts from the council or staff? Okay. One item that I'd like to change in the order of the agenda is the update from the health strategist, Dr. Nguyen. He's going to be available from 1:30 to 1:45. So wherever we are at that point, I would like to divert to Dr. Nguyen to give him the opportunity to engage with us and then the freedom to get back off to his other commitments. Are there any objections? Hearing none. Staff, would you let us know when Dr. Nguyen comes in on the call? All right, so then we'll start off with the second item on the agenda, and that's updates on testing and how testing is currently designed to inform COVID response strategies. I've had questions about this already from a few people, and that was the idea of, can somebody, even before we go into these individual items and how they inform COVID response strategies, clearly articulate the public health strategy we're using so that we can—
Hey, Dwayne, this is Tara. I do want to just make, and Dirk briefly touched on it, but I do just want to make sure that the Health Council is aware that anything that's a disease control record is confidential, or it's not available for public disclosure pursuant to North Dakota Century Code 23-7-20.1. And so to the extent that we're getting into information or that questions are coming where we feel that they've reached the level of disease control records, we may have to ask employees to stop, and we may have to discuss whether or not this council needs to go into executive session.
Does everybody understand that, council members, staff as well, that if we feel like we are getting close to that line, we need to go to an executive session? Okay.
Yeah, I think we can stay broad enough with what's the strategy and not get into individual records where we risk that.
All right. Dirk, would you or one of your staff feel comfortable in laying out what the clearly articulate what the actual strategy is?
Well, I'm going to defer over to Nicole Brunel, who is our testing and strategy, our testing lead. And so I think she can give you an overview of what's happening, and then maybe you can see if that meets your needs, and then we can follow up from there.
Thank you, Nicole.
Good afternoon, everyone. Hi, thank you so much for having me a part of the meeting today. I'll just give a little quick overview of kind of what we are doing and what we're working with. I will ask to share my screen. I do have a couple different slides. And are you able to see that? There we go. All right. So the section is the research and response section that was created with Dr. Andrew Stahl back in June. Our main priorities and testing strategy is based off of community outreach with our static and mobile testing events, local public health, tribal, homeless, and frontline businesses. Our next one is our priority area right now in the state in the congregate living, long-term care facilities, corrections, group homes, university, and colleges. And then we also have a large amount of diagnostic testing coming from the hospitals, critical access hospitals, clinics, and our FQHCs. So based off of those areas, our testing strategy, we collaborate with disease control and epidemiology. We work together with identifying the community outbreaks where the causes may be coming from and identifying the source, and also utilizing the Smart Restart county levels and the positivity rates to base our testing events and availability off of those. We collaborate with the VP3 team and Long-Term Care Association with monitoring closely and identifying the facilities that are having outbreaks and prioritization with those with the staff and residents. We also collaborate with the State Public Health Lab closely with our lab capacity and also new testing capabilities that we would be able to validate with the lab to assist with further testing around the state. And we also are very closely working with the local public health districts, all 28. We developed 8 regions back in June and identified 8 regional leads to be under and overseen by Sherry Adams as our executive consultant for that. We identified communities' testing needs based off of the reported hotspots and also just their basic knowledge of their communities, what they are seeing, if it's street dances or rodeos or any large gatherings, we know that that could potentially lead to an outbreak. So we will look at that targeted area or community and host testing events to stay on top of it, to identify those positives to stop the spread. Anyone have any questions?
This is Kristen. One question. So I'm actually driving through South Dakota right now. Sorry. Am I causing that bad echo, or is that? Okay, sorry, it got real bad for a second. I'm driving through South Dakota right now, and just seeing in the news and seeing on social media the difference in philosophies between North Dakota and South Dakota in their approach to testing. Can you just explain a little bit about how do we determine how much testing is enough testing, how much testing is too much testing, that kind of thing? Because I know there's a lot of emphasis on, some people really want us to focus on what our positivity rate is, which incentivizes higher levels of testing. You know, just can you help me understand just that bigger picture?
Well, we truly believe, and we follow the CDC guidelines with, providing testing to those, whether they're asymptomatic or symptomatic. We want to be able to identify those positive cases, especially the asymptomatic ones, to prevent that spread in those areas. So the positivity rate, I know there's a lot of attraction to that, but we really want to concentrate on our hospital capacity, our deaths in the state. How can we prevent these individuals from dying or even to be hospitalized? If we can stop that spread in the community before it gets into those congregate areas and living communities, is really our goal, is to stop it before it spreads.
And then just one follow-up question when you talked about deaths. One of the questions that I get asked pretty frequently is, how are our deaths month over month comparing to previous years for any cause? We're just so laser focused on COVID deaths, but are we seeing a equivalent decrease in other causes of death, i.e., are we having the same number of deaths a month than we would expect in a month, just for different reasons, or is this a true increase in the net deaths by population?
And I would refer that question to Kirby Kruger and the epidemiologist. I'm not sure if they have that data right offhand, but Kirby?
So Kirby, is it additive or compensatory, and can you describe that relatively well?
I don't know if I'm in a good position. I don't have that background data just right in front of me right now. So I'd not be able to provide an answer to you right now. So on that. So, and I'm not sure if anybody from analytics could, so yeah.
Is that something that you guys could take a look at? It's a very frequent question that I get. So it'd be very helpful to be able to answer and say, no, this really is a net increase in deaths, or because I think people are trying to sell it, and to be honest, my own belief, just working in a hospital, I believe that it may not be that large of a net increase. And so it's a difficult answer when you don't have the numbers to be able to back it up.
Council members, Dr. Nguyen has joined us. So if we could, and being respectful to his short window that he has available to us, I'd like to make him available to us in a change in the order of the agenda. We'll get back to testing in a moment. Dr. Nguyen is the state health strategist for the governor's office. He is also the dean of the medical school at UND, and I've asked him if he could come on this call today and describe his role as state health strategist, what types of strategies he's been working on with the governor's office, and where he sees his role fitting with basically the roles of the state health council. So Dr. Nguyen, please go ahead.
Thanks very much. Good afternoon, everyone. Hi, friends. Nice to see all of you again, even if it is virtually. So just when I thought it was safe to go outside, COVID notwithstanding, after my one-year term as interim president of the University of North Dakota, I got a phone call from the governor, and he asked me if I would help head up an effort to develop a strategy for health, and not just public health, but health for the state of North Dakota, with the very modest goal of making North Dakotans the healthiest people in the country. And I gulped and I said, that's interesting. And he said, oh, and yeah, we want you to come up with this strategy by the end of the calendar year. So this was in June. So we've been scrambling to try to develop such a strategy. And maybe if I can try to share my screen, I don't know if I've used this app before. Let me, I don't see my, here it is, okay. Are you seeing that?
Yes, we are.
Okay, so the question was to try to come up with a plan for health for the state of North Dakota. And the idea that we had was to not only just try to incrementally improve things, but to, as the quote says, do better things instead of simply doing things better. So we've been working really since June to have some of us work together to at least address what the questions are. So through the summer, in June through August, a relatively small group of mainly representatives from UND, NDSU, the Department of Health, and the governor's office interviewed national experts and thought leaders in health improvement and innovation. Starting in September, we started interviewing some local experts about the same thing, so we could sort of start to develop the framework for what the phase that we're in now in October and November is convening groups of not only the planning group, but multiple stakeholders, including state agencies, health services, legislators, providers, and so forth, to determine and refine the plan goals and objectives, with the goal by the end of the year to have a plan back to the governor and then in January for the legislature. We've developed a broad range of basic principles or guiding principles, including the idea that we want to try to get all North Dakotans to not just get good hospital care, but to live their best lives as long and as fully as possible. The idea of flourishing. We believe that working together is important, and what we've focused on is a broad definition of wellness rather than just the absence or the treatment of disease. And we want to be both bold in our approach, but also to prioritize interventions that are measurable and accountable, And we realize that this is not something just for this legislative session or this governor, but rather for the long term. And to make North Dakota the healthiest state in the country, we believe very much that we need to take a population health approach founded on 3 pillars, focusing on policy and decision-making, leadership and expertise, and collaboration and integration. One of the examples of the policy and decision-making is what has been called a health in all policies approach. That is to really have the legislature and the agencies of the executive branch understand that things that they do, even if it's not directly related to healthcare, may well impact health from a community standpoint, and therefore to get the awareness that all policies should be evaluated through the lens of how it's going to impact health. To look at barriers to healthcare, to look at alignment of policies and benefits with the focus on a population health approach. Obviously, particularly for the physicians who make up the majority of this group, looking at individual health is important, but we know that many of the challenges go beyond an individual patient and relate to communities and populations. And finally, we really do believe in data-driven decision-making. In leadership and expertise, I think most of us would agree that there has been an underinvestment everywhere, including North Dakota, in the public health workforce. Certainly, it's important that we need to combine better prevention and acute care. And we feel it's very important, particularly in a state like North Dakota, to empower leadership and to have this approach community-driven. Yes, there need to be broad precepts that come from the state level, but the implementation needs to be in communities and by communities. And then finally, we believe as broad precepts, the critical importance of collaboration and integration. Obviously, tribal health is a major challenge in North Dakota, many challenges, but also many opportunities to improve things. One of the things we've learned, if we didn't know it already from the COVID experience, is that we have to get much more developed communication and coordination between state and local entities. The planning group working on this has no preconceived notions about the relationship, for instance, between the Department of Health in Bismarck and the local public health units, but optimization of that relationship has proven to be very important and will be critical going forward. And similarly, there are incredible opportunities for further communication, coordination, and simplification of service delivery across the public sector, but also the private sector. One of the things that's obviously a big issue, and we don't have any preconceived notions of how to do it better, but is to even improve even further the coordination between human services and the Department of Public Health. Clearly, from a patient standpoint, a client standpoint, there are multiple portals of entry, and we need to do better to really improve that for the citizens of North Dakota. So that's just a brief overview of of where we are. We've spoken with some of you already, but I anticipate in the near future that we'll be speaking with more of you, and presumably the entire Health Council, depending upon what your desires are, as we try to tease out, based on these principles that we've established, what an actual health plan would look like. So I know our time is limited, so I would pause there and I'd be happy to entertain any questions or comments. Thank you for the opportunity to visit with you.
So, Chairman Poole, this is Daryl. Could I ask a question of Dr. Nguyen, please?
Certainly.
So, Dr. Nguyen, it's great the work that you and your group are doing to develop additional strategies for the future, and appreciate the work that you are doing. Does some of that work that you're doing involve current issue advisory? Are you part of an advisory group then that provides Dirk with some guidance, or is that a role that's separate? Is there an advisory committee, I guess? Maybe you could expand?
Sure. The direct answer is no. It was very clear from the governor that this is forward-looking and not directly about current operations in the Department of Health. So we've had no direct interaction on that. Now, Dirk and his predecessors, or at least his predecessors, have been involved in these discussions. So the prior state health officers were all involved in this, but not to address current activities. Having said that, the Century Code indicates that when the state health officer is not a physician advisory group it needs to be appointed by the governor to advise the state health officer. And four of us, I believe it, all have accepted it to work with Dirk. Four of us have been asked by the governor to continue to serve in that function. And the four of us are me, Mary Allman, Fidel Namor, and Andy McLean. So four of us do advise the state health officer, and we have not yet met with Dirk, but given the recent changes, that presumably is on the agenda. So I have some role wearing a different hat to advise the Department of, well, not the Department of Health, the state health officer, as specified in the Century Code.
Jim Russo here. I've got a question for you.
I'm sorry, Jim.
Yeah, just a question. We're not quite sure of our role, I guess, in all of this. According to the Century Code, the State Health Counsel is supposed to advise the state health officer. So, but we've sort of been left out of this process, and we don't have a voice in this strategy plan. That has me concerned. I don't know if you have any worries about that or if others on the committee do, but it bothers me.
Well, no, I think maybe you misunderstood me, Jim. And by the way, good to see you again. We are now in the phase of our plan where we will be meeting with important groups such as yours. So that's actually, I have a meeting starting at 2:30 this afternoon where we're actually compiling a list of the groups and individuals and constituencies that we need to meet with. So you're high on the list of the next phase in this plan. So I would not have worries if I were you.
Yeah, this is Tara. I do want to make a clarification, and I do want to make sure that we're sticking to the agenda items as well and not going outside the scope. But the first thing that we need to talk about is there are two different bodies. There's a health council, which statutory duties have, again, primarily been limited to and used in the past as that regulation or the rulemaking entity. And then there's a second body, which is considered the Physicians Advisory Board. These are two entities that are created by statute. The Physician Advisory Board, as Dr. Nguyen said, only comes into place when the state health officer does not have a license to practice medicine in the state of North Dakota. So as we know, Dirk is a lawyer. The statute implicates the need for a physician advisory board to provide him with the physicians, or in this case, those four, would advise him on medical needs.
And I'm terribly sorry, but I have a hard stop right now due to another speaking engagement. So I beg your deference, but I'm going to have to run at this point.
Thank you, Dr. Nguyen.
Nice to see all of you.
Yeah, and hopefully we'll be in contact again to help clarify roles and our role in helping develop strategic plans for the state.
We look forward to it.
Thank you. Okay. I guess we'll return back to testing and testing updates and questions with regards to testing. I think there were some questions on the table relative to the strategic direction that testing is apportioned by and how those apportionments of testing help inform those strategic directions to better provide tools to protect the public. I have a question as well, and that is, are we at the point now of knowing whether or not this is a deterministic, predictable spread, or is it a series of stochastic clusters? And how does the design of the testing strategy address the need to understand those different mechanisms and the tools that would be necessary to interdict?
I think the first part of that question, Kirby would be able to answer in regards to where we're at with the community spread. I don't know, Kirby, did you hear the first part of that question?
Yep, I did, and thank you. And Chairman Poole, this is Kirby, and I'll look at my computer that has the camera so you can actually see me. The fact of the matter is that we have seen a shift over the last couple months. Earlier on in the pandemic, our investigations, many times we were able to link cases back to a smaller cluster or a larger cluster that were occurring, or back to cases that, known cases that had been identified. But as the pandemic continued to grow and cases continued to grow in the state, we have seen a shift to what we call more community spread, where we're not able to identify exactly where a person may have picked this up. They're not part of a cluster that we're aware of, or they're not part of they're not a known contact to a known case. So, yeah.
Well, to that end, then, I understand contact tracing, that there's forward tracing, which is more to protect the exposed from further dispersion, that sort of thing. But there's also the backwards relationship in tracing. Given the overwhelming numbers that I understand that you're dealing with, are we limited in capacity to only addressing forward tracing, and do we have the capacity to look at backward tracing to address those issues of clusters that you're talking about?
We do. We try to still address those issues with our interviews, and I know that the term contact tracing and case investigation are often interchanged, but in our case investigations, where we're actually having a conversation with the people who are infected, we do try to figure out what their source of infection is, because to us, being able to identify those clusters helps us understand where we need to be focusing testing, if we need to shift some resources for testing, or if we need to increase some communications amongst a group of people, we can try to do that. But we also have to you're right, and we do spend a significant amount of time trying to understand who their contacts are, so those individuals can be put into quarantine, and that is to prevent further spread of disease. Yeah. So, but we do try to figure out a source for every case. We try to figure out source and spread. That's the two areas. So,
are there any clear results coming from this that would allow for specific strategic actions or targeted actions that would help break up typical clusters or typical higher probability spread circumstances?
I think so. And this is all very practical stuff that I'm talking about here. From our perspective, when we can identify an event that appears to be an issue where there's a potential for a large number of exposures. For example, a large gathering, a wedding, or something like that. When we identify those, we work real hard to try to work with those parties to try to get information on how many in attendance. And then we have to work real hard to try to get these individuals to understand that, because we're not going to be able to get the names of everybody, and we're not going to be able to contact everybody at a 300 plus wedding. It just doesn't work. We don't have that bandwidth. So we work real hard with the wedding parties, to try to get information out through the means that they have available, whether they have email addresses or whatever. But we rely heavily on them on those large situations. In that process, though, Chairman Poole, any named contact that we can identify will get notified by one of us. So it's if somebody can name a name and say this person is a close contact, that is sort of the deciding factor for us that we are going to be making a notification. So.
Okay, I think part of the point of my question too was that you'd suggested something like wedding parties. So actually, the level at which I was trying to get to was identifying events like weddings or specific types of events that the governor's office and Dirk could advise on would be very targeted points of intersection of public health with public activities to help break the spread at an event level, not necessarily at the individual level or at the probability of exposure level.
Yep. And I think that's part of the guidance that has come out now with the revised guidance for gathering, in those sizes, trying to reduce the number of people that are at these events, which is all guidance, as you know. So.
And that's one of the great things about working with the local public health across the state. They really try and stress these guidelines to their commissioners and their county commissioners on those events that we could possibly prevent, such as a street dance or a fair. So really trying to get everybody on board so we could be proactive instead of reactive.
Yeah, and you're right, Nicole, and council members. Local public health has really done a great job of trying to keep that pulse in their communities, and they do work hard to try to limit some of those events. So,
I don't know about the other members of the council, but I've been reached out to by members of local public health units, and they are fighting a really tough task. They are not always met on the other end of the phone with the gratitude that you would expect with somebody who's only looking out for their particular health and the health of their loved ones. They're also meeting with animosity, which is really, really draining and hard on them, along with just the personal stories that they hear on the other end. And I think that it's, if our news media and others could really spread the message or the word for us that, this is not the person that your anger is with. This is the person who's reaching out to help you and help your neighbors.
Chairman Poole, I'd also like to add on to that in regards to local public health. I think one of the biggest struggles that they're having right now is trying to provide a unified message statewide on what needs to be done and having that support of what that message needs to be. I think sometimes they're having difficulty of thinking this is the direction they need to go, but that may not be the message across, whether that's state officials or the like. Really being able to have that one message coming across from all facets of government and being able to provide that together as one unified message across the state for the citizens. I know that that's been a real struggle for our local public health units.
I agree. And I've heard back from various people within public health units that they feel significantly constrained by their local governments, as well as feeling like they're not getting the support that they need to do what they have to do from a state level in terms of being able to be more active in constraining the virus and the spread. I don't know who on staff would be able to address that or has thoughts on how we can be more responsive to the needs of local public health. But as a state, the message has come out that we're all in this together. And I think we need to be very cognizant of especially the local needs where they feel constrained at the political level locally.
Yeah, Dwayne.
Chairman, I'm sorry.
No, go ahead, Jenny.
I was just going to ask a question for Kirby or maybe for Nicole. With the increase of testing, increase of positive cases, what is that doing with the amount of staffing you have for tracing and being able to make those phone calls? Is there quite a backlog? Are they able to continue to keep up with the pace? I can't imagine with the number of positive cases coming down, what does that look like?
Jenny, I'm going to have them answer that question after Dirk follows up with his response, if that's okay.
Well, my response is sort of a non-response, which is unfortunate, but I just want to remind that we have to stick to our agenda. And so when we're kind of drifting off onto talking about local public health and things that might be outside of that topic, I just want to make sure that we're buttoned up on the areas we can go, since this is a special meeting and not a regular meeting. So it's a very important question. It's just I'm not sure that's a topic that we have on our agenda.
Okay. Thank you. So, Jenny, is your question still out there on capacity?
When I'm looking at number 3, and maybe we're not there yet, about update on contact tracing and how these inform COVID response strategies, I was just curious to know, with the increase in positive cases, what that's doing with the workload of our tracers, and do we have the capacity to be getting back to these individuals in a timely manner, or is there quite a substantial backlog? I was just curious.
Is everybody comfortable with moving on to an update on contact tracing and a follow-up then to Jenny's question? Okay, we're on to item 3 then.
Okay, so I'm just going to give you some background information on how we've sort of assembled our team here in disease control. With the additional federal money that we have received, we've been able to assemble a team of contact tracers, some of which are directly employed by the state health department. Others who are employed through contract are doing the work through local public health through some of the federal money that has been allocated out to local public health. We have a program manager that we were able to hire that sort of is in charge of overseeing all of our COVID activities in conjunction with our regular staff. 16 case managers. We have 8 regions in the state that we've divided the state up, and so we have 16 case managers that are working in those regions. And then we have a team of healthcare-associated infection experts that are responsible for reaching out to healthcare facilities and long-term care facilities and working with them when they have identified cases or contacts and providing guidance to them. But we also have a team of subject matter experts. There's 8 full-time or part-time people that help us to work with businesses, K through 12 schools, universities, travel-related cases, and then homeless individuals are shelters. In terms of actual caseworkers, the people who are on the front lines doing the work, we have 163 employees that we have hired directly within our health department. Then we have contracts with UND, NDSU, Minot State University, and a private company called Rose International. So we have the 163 employees here. UND and has got 82, and they're building to where they want to be is at 109. NDSU has 49 individuals. Minot State, that contract just got completed, and their goal is to hire 15. And then this Rose International, we're going to start with 10 there. In addition to that, we have 17 individuals from the state health department that work on the school team that help with the schools that have cases and doing that contact tracing within the school system. We have local public health, especially Cass County and Grand Forks County, that still have continued to do their own case investigation, contact tracing. So there's a number of individuals there. The smaller health units, they do assist with some of the case investigation and contact tracing as they have time, but more and more their priorities, and rightfully so, have been shifted to testing, influenza vaccinations, which are extremely important, and to preparing for COVID vaccinations. We also have the National Guard that is helping us, and we have 50 individuals that are doing contact mapping for us, and they're basically the same as our contact tracers. The model that we have with the National Guard is that when we do our case investigations, our staff, are the college staff, whoever's been assigned the case, they'll do the work and they'll do the contact tracing part for the household contacts. The non-household contacts that are identified, the close contacts that are non-household contacts that are identified in our processes, we will give over to the National Guard group, and then they do the contact notifications just for those contacts. So they're not doing the complete case investigation at the National Guard level. What they're doing is just helping us with that contact tracing part of it and notifying contacts. So of our employees that we have in disease control that are doing this work, most of them are part-time. In September, I had close to 2,900 person hours per week that were available to me for contact tracing, just based on the timesheets that were submitted in September for me. So you can see that the 163, not all of them are full-time. And so many of our individuals that we have hired are people who are students, or they have part-time jobs in other areas, or they have full-time jobs and they're just looking for some extra income. And so that's sort of the status of that. We're continuing to build our team. And to get to Jenny's question is we have been able to keep up, but this last week has been a challenge. And so our goal is to reach 85% of individuals within a 24-hour period. And we've been able to do that up until this week. And this week, I don't have data yet, but I know that last night that we had some that were still being assigned out. So, but we're hoping that we can get that caught up here. So I can tell you that overall, we're reaching about 93% of the individuals within a 24-hour period. And I can tell you that out of those that we, out of everybody that we're following up with, there's about 3% that we just failed to make contact with. Either they don't respond to us, or we don't have the right locating information. But there's a failure. So, but by and large, we're able to get through in a timely manner. So,
Kirby, this is Dwayne. So off that 2,900 hours that you have a week, that's a week, right? Not per day.
Right. That's person hours per week. Yeah.
So how many new contacts have we been averaging the last couple of weeks?
Oh, I wouldn't have that data off the top of my head. But I can tell you that we've been averaging between 4 to 5 contacts outside of household contacts per case, somewhere in that neighborhood. So
yeah, I'm looking at that number saying that's less than 1 hour per contact you need to make, and that's without even thinking about the follow-ups for the 10 days of isolation or 14 days of quarantine that has to go on contact tracer side. I completely understand Jenny's question about, are we hitting limits of capacity, and how do we address when we do hit those limits?
So, and just to be clear, so that's where we have these other entities that are really helping us out, because Cass County is doing the Cass County cases, Grand Forks County is doing the Grand Forks County cases. UND, the contracts with UND and NDSU, those individuals are helping out statewide. They're not just limited to NDSU or UND cases. So we have those other resources that are also helping with this process. So
So that's not part of that 2,900 hour availability. That's
No, that 29 is just what I can control from my level. So, that are within disease control. So.
Thank you. Commission members, questions for Kirby with regard to contact tracing?
Jim, again, I have a question for Kirby. Do we know once a person is contacted as having been a contact to somebody who's an active case, do we know what percentage of those people actually go into quarantine?
So we have a rough estimate on compliance, but the definition of compliance is wide, and the data that we have to analyze it isn't real specific. Compliance can be anything from an individual not returning a follow-up survey, because once we identify a contact and they go into monitoring, they get sent a survey every day that they're not supposed that they send back to us, and that survey basically is asking if they have any new symptoms and if they're complying. And if they don't send back a survey, they fall out of compliance. All right, even if they start sending the survey the next day, So that's one way that they can fall out of compliance. Another way they can fall out of compliance is if they tell the contact tracer or the case investigator, I'm just not going to listen to you, and I'm not going to follow what you tell me. Right. And then the case investigator can go in and mark that person as non-compliant. And then there's a third way that we can measure non-compliance, and that's if on the survey they send back that they mark that they're not going to comply with the quarantine anymore. And if they mark that, then that's the third way we get a non-compliance. Yeah. So the last time we ran the data, and it's been several weeks, for about 70% of people were in compliance, about 30% of people were not in compliance based on one of those criteria, okay? Yeah. So we don't know how much out of compliance they are, whether they were staying home, and just didn't return the survey. That's one factor, or whether they were just totally ignoring what they needed to be doing. So,
and I'm assuming that many people are being truthful with the contact tracers in that data collection.
I think Chairman Poole, you hit this exactly on the head. Is that throughout this whole process, we're basing all of this on the people's ability to fall into compliance with us, and that they're complying with us, and that they're being upfront with us on everything that they're telling us. Our contact tracers will be the first to tell you, our case investigators will be the first to tell you that, oftentimes people will give some contact names, but they won't give them all. And they'll just say, I'm not going to give you the other names because I'll tell them myself, or whatever reason, and we try to do the education, and we try to get them to understand why we're doing what we do and why it's important. But at the end of the day, it's voluntary compliance. So.
It's Jim again. I just want to say that this is a monumental problem, but I think the response of the state lab and also the Division of Disease Control has been really pretty phenomenal. I saw that they reported 10,000 tests yesterday. I don't think they were ever planning on doing that many in a day. And I also want to know that I want people on the council to know that this hasn't gone unnoticed, because today both Kirby and members of the lab and the Disease Control Division are being recognized by the North Dakota Medical Association and the American College of Physicians for their tremendous work.
Congratulations, Kirby. It's very well earned by you and your staff, and I know how humble you are, but I'm still going to put some praises upon you for leading that staff.
It's a team effort. It really is.
So, I guess, are there any other questions for Kirby with regard to the contact tracing? If not, I guess I'm going to circle back then to sort of the framework that we've been working in, and that this is an interesting update on the contact tracing. How does the compliance estimate, the number of contacts per individual, how does that feed back then into a strategy to address mitigating the spread of the disease other than individual isolations? Is there a more focused look on how we address strategy beyond the individual mandate of, or shouldn't say mandate, request or urging for quarantine or isolation?
So I think my response to you is less big picture than what you asked me, Dwayne. It's really where we've seen the benefit of contact tracing is the ability to identify these small clusters that are occurring and being able to intervene in these clusters, whether it's a wedding or whether it's a workplace or it's some other event or it's a gym or whatever it is. I think one of the advantages of being able to do the contact tracing has been able to identify these smaller clusters that seem to occur. And, it's hard to imagine that as much community spread as we have going on in the state, that you can still identify clusters, but we still identify clusters. And so that really is helpful for us. The other part of this is without the contact tracing, the contact tracing allows us also to identify if there's a healthcare facility or a long-term care facility that may be at risk because the person who is named as a contact is a worker in a healthcare facility. And so that gives us a heads up in trying to get ahead of something that we might be able to prevent in terms of an introduction into a long-term care facility or another institution. So
I guess I have a question related to that, and that is on the it bridges contract tracing and data analyses, and that is the retroactive PCR approach to testing facility workers sufficient? Because we know that they are significantly contagious prior to testing, as well as the time that it takes for the return of the test. Is there another mechanism of testing that would better serve the strategy of dealing with those types of venues?
I think from my perspective, now I'll let Nikki jump into this, but I think that's part of why we are trying to do more routine testing in facilities in the state versus just reacting to cases. Some of it is reactive, and we do increase our testing in facilities when we do find cases. But I think you've pointed out one of the challenges with this particular disease, because doing case investigation and isolation and quarantine is not a new phenomenon for infectious diseases. We do it for other diseases. We do it for measles. We did it for Ebola, or we were prepared to do it for Ebola. Certainly with Ebola, it was much easier. People are most infectious when they're later in their disease. But as you pointed out, people are most infectious right before they develop symptoms, and within that very first couple days of their acute phase is when they're shedding the most virus and probably the most infectious. Well, by the time we are involved in doing our work, they've already been probably been through their most infectious period already. So that does put us behind the 8 ball with this particular disease. So
good infection control is very important here.
That's exactly right. And I think I'll just say, Faye Salzer is our team lead for our infection control, and that team works long hours every day, trying to provide guidance and coaching to the facilities, trying to do their best to keep what's happening in their community outside of their facility. And that's, I think, has been the key challenge. So
I think I better give my wife credit for this, because she's the one I first heard it from several months ago. And that was, you don't have to be a medical practitioner to understand the value of wearing a mask or using proper infection control techniques. All you have to do is think about whichever loved one you have that's going into surgery and ask whether or not you want the doctor to wear a mask. All right, since we're in data analyses, are there any other questions from the council members with regard to data analysis?
I do have a question. Certainly data is important and taking a look at the numbers as strategy is developed. I'm hoping and assuming, based on Dr. Nguyen's comment, that there is a physician advisory group that provides guidance from a strategy or from a science perspective as well too. So is there that group, and how are they providing guidance, and how is that being utilized? Because, you know, as a CEO too, I can make decisions based on what I think, but I certainly count on expertise such as our providers, et cetera, to help lead us. So Dirk, it's a long-winded question, but how is science taken into account when strategies are developed for response and prevention?
Yeah, I would say that it is definitely a part of the equation. So not only do we have scientists as epidemiologists and throughout the health department, like Kirby's team, but we did activate a couple of physicians to help assist me in addition to the advisory groups that we've been talking about. Dr. Paul Carson, for example, he works at NDSU. He's an infectious disease specialist. He has been very instrumental in giving me guidance. We have a field medical officer, Dr. Joan Connell. I talk to her every day in stand-up meetings. We have Dr. Guy Tangadal. He helps us with our school discussions. So we make sure that we do have experts in the room, not just physicians, but public health experts. And we do utilize the whole of government approach. So we work with Long-Term Care Association. We work with the Department of Human Services. We work with DES. We make sure that we get experts in the room to have those conversations.
Dirk, this is Tyler. I have a question. Have we been able to, or has the organization, as far as looking at response strategies, have we been able to look at current or past positivity rates to predict where the next spike may occur, to target our resources more in those areas? It's interesting because I'm not an epidemiologist or a expert in statistics or anything, but I was putting our numbers into just some easy control charts and looking at the increases in levels on a day-by-day basis and seeing how fast they were rising in certain reservations. And it was pretty easy for me to predict when we were going to have a huge spike in one area. So do we send more public testing events to those areas when we predict a spike, or how have you guys been doing that?
Yeah, I'll have Nicole answer that question, but it might be helpful to have Grace walk through her health analytics presentation, which actually addresses part of what you're talking about. So maybe that'll answer some of your questions. Then Nicole, you can kind of finish up in terms of the testing resources that are allocated to those areas, if that's okay with you, Dwayne, and you, Tyler.
That's fine. Go ahead, Grace. Welcome.
Sure. Good afternoon, and thank you for having me. Clint, do you want to load the PowerPoint, please? If you can share, I think that would be great. Great. Next slide, Clint. Great. So the Special Projects and Health Analytics Group is new to the department in some ways. I am trained as an epidemiologist, and I did work as an epidemiologist for DOH, but as COVID started, there was an information and intelligence team that was part of the Department of Emergency Services, and that started in April, and then as of September, it was moved to be under the Office of the State Epidemiologist, where I work, and so that's where this team is housed. And currently we have 8 data analysts who work full-time, and their key responsibilities are, one, to really do some of the things that you all have been talking about. We do have team members to conduct extensive literature reviews and look into the qualitative research around COVID. We conduct a lot of the data analysis and products that you see out there, such as the websites and the dashboards and those regular updates that happen either daily, weekly, or as frequently as they are requested. We also respond to data requests from both internal and external partners. And overall, we do this by collaborating with other state entities and also some internal stakeholders, such as Kirby's group and also Nikki's group, to kind of like tie it all together in terms of the data products that we produce and for them to be useful and meaningful for this operation. Next slide, Clint.
Chairman Poole, is there a possibility, I'm seeing the PowerPoint slide is in a very small box and I'm unable to view. Can that be put in a larger box to be able to see the slides?
Clint, you're familiar with this technology. Is there a way for us to blow up this individual screen? Because it shows like just a small individual video window as opposed to filling our screen.
Thank you.
That did not work, Clint.
Hey, Clint, this is Tracy. Do you want me to try to share my screen?
Well, I think it'll probably do the same thing. I think it has to be shared by Grace as she's talking, I guess.
Yeah, let me see if this works.
There, perfect, Grace. Thank you.
Okay, perfect. Let me just. Great. So in addition to some of the other data products that you see, such as the Smart Restart dashboard or the NDUS data products and the Tribo dashboard, we do share other outputs that are a little bit more targeted that help kind of like tie the intelligence together. And this is just one of the examples. We have been calculating the basic reproduction, well, actually the effective reproduction number for North Dakota. And this is just the average number of secondary infections.
We lost your PowerPoint again.
Oh dear, not sure what's happening. Okay, what do you guys see?
We see you.
Oh, okay. Let me try to stop and start again.
Grace, if you want to email it to me real quick, I can share it on my side.
Sure.
Yeah, Grace, I already have it pulled up. Let me try.
I don't know if it's going to show up on a small window on your end if you guys are the ones doing the sharing.
It worked with Nicole though, so I think it should be fine.
Right.
Okay. Nicole, want to try?
Grace, are you on mute?
Yes, except I don't see the screen now. So I'm assuming we're on the slide with all the text.
The R0 and the RT?
Yes. Okay, and I kind of like know the spiel anyway. But really, this is one of the products that we produce weekly, and it's just an estimate of the secondary number of infections that are being produced by each case. And so if you go to the next slide, I believe the next slide just kind of like gives you a simple breakdown of what an RT actually means. So this is just an example of like, when you have one case with an RT value of 1.5, this basically means that each individual case has the potential to transmit this to 1.5 people. And so 2 cases would then give it to 3 people, and then 4 cases would give it to 6 people. And so with an RT, what you really want to be in the ideal situation is you want to have a low number of cases and also the RT to be less than 1. Because for as long as the RT is 1, you are essentially transmitting the disease to one other person. When the RT is greater than 1, it means that the disease is actually spreading to more than one person. And so best case scenario, low number of cases, and then also a low RT value. And then in the second best case scenario, what you really want is a low RT, but also a low number of active cases. And then in the worst case scenario, is a high number of active cases and a really high RT value. So if you go to the next slide, I believe our RT value for this week was about 1.1034. So we are still in a situation in the state where the disease is being transmitted to more than one person. And this is especially significant to note because when you do have a high number of cases, the RT value becomes even more meaningful. So for example, back in March when the RT was 1.8, we had a very low number of cases at the time. And so really the transmission was not going to be as significant as it is now, where you have a really high number of cases and then an RT that's higher than 1. And so when you think about these numbers, it's always nice to consider that, you know, an RT of higher than 1 with a high number of active cases could really point to we're now going in the right direction. Next slide. And weekly, we do estimate what this looks like at the county level. And so we try to get these numbers to individuals who are working at the local level to make sure they have an idea of what's going on at each county, and then over time what that looks like. So the same sort of like graph that I had with the state, we do produce something similar for counties.
Grace, do you do any correlations with specific demographics or behaviors in relation to those rates of transmission?
At this point, we kind of like all tie it all together because really our role has been to look at all these, you know, data pieces. So the RT is one piece. We also look at, you know, daily positivity. We look at the rolling averages. We look at testing capacity and all these things to sort of like bring recommendations forward. And so, yes, we do factor that in, but they may not be necessarily built into this specific model.
And then I have one other question. In the RT values that you have, how does clustering or individual super spreaders manifest in the way that the data is displayed?
So some of the key inputs that go into this model, aside from like the basic assumptions of like, you know, the incubation period and the transmissibility of COVID, is the daily testing and then also the daily positives. So the model as it is set up, it basically scans about 10 days backwards to estimate, like, you know, 10 days ago, the number of cases that we had then, how much do they explain the number of cases that we're seeing today? And so really the main variability comes from the number of cases tested and then the positives that you see every single day. But that looking back for 10 days does allow us to smooth out to essentially adjust for any differences in testing on a day-to-day basis.
Okay, so it's pooled data. It's not tracking individuals to get to this and then doing an overall population metric.
No, and it is doing this at the county level, and so it may not pick up on like, you know, the exact clusters, but one of the things that it does pick up is you know, large events that may influence an area like say McHenry County, where you had you know, all of a sudden there was, you know, an increase in the number of cases, and this is all publicly available data, and this just happened over a 1 week period, and we were quickly able to see that in the RT value of how that spread in that community. Next slide, Nicole. And then the other thing we produce is the changes weekly, just so communities are aware of how they're doing. We've had some communities go under 1, come back to over 1, but this is a chart that we share with the Unified Command and the, pretty much everyone who is in this operation, so they have an idea of week to week how we're doing. Next slide, Nicole. We also tend to produce outputs that show the rankings for, you know, by county. So like the current hospitalizations, rolling day average for testing, positivity, long-term care case counts, and then also, I believe these are just some of the metrics that may help you look ahead in terms of like anticipating where do we expect, like, for example, the highest number of hospitalizations in a county, or the highest number of deaths where they could potentially happen just based on the fraction of the cases that are, you know, long-term care or older adults or individuals with high comorbidities. Next slide, Nicole. And I think some of you may have seen this chart, but it's just a summary of just the probability of death just based on age. And we've grouped this from intents. The first column is showing the COVID infections and followed by hospitalization, deaths in hospitals, and then the chances of hospitalizations, chances of death in the hospital, and overall chance of death if you do contract COVID in North Dakota. And I think this is, commonly known, as, older adults are certainly more vulnerable, but, comorbidities are more common in the general population than we thought. I believe it's upward of 30%. So really, as much as we would like to think this may not affect, you because you're young and healthy, this table does show that, we, at some point, I think the risk of hospitalization or mortality is something that we should all be thinking about as we practice, safe hygiene and all the other protective measures that Kirby's group has recommended. Next slide. And I think we touched on this, which was community spread. So this is another measure that really sort of plays into looking ahead. And we are seeing, in most counties, upwards of 50+% of individuals cannot trace the source of where they acquired COVID. And so for these cases, I think it really does inform, the testing strategy. When you see a high proportion of individuals in a community who are positive, saying they have no idea how they contracted COVID, it becomes even more important to make sure that testing is widely available in those communities to really be able to identify the sources of transmission and then effectively isolate or quarantine individuals as needed. Next slide. And I will turn it over to Tracy.
All right, thank you. Hi, everyone. My name is Tracy Miller. I'm the state epidemiologist, and I just wanted to briefly go over a new project that we have been working on for the past several months. It's wastewater surveillance. I don't know how many of you have heard of it. The Centers for Disease Control has actually started doing a national wastewater surveillance system. However, we started just a little bit prior to this. It's data from wastewater testing, obviously is not meant to replace human clinical testing or anything like that, but it's really meant to be more of a complement to the ability to do community level testing in like a pooled sample, especially in areas where clinical testing is not available or is being underutilized. And so, as you know, wastewater is referred to as sewage. It includes water from households, buildings, where we are collecting human fecal waste. And the reason for that is because it can be tested for the COVID virus that is being shed through the stool samples or through the stool. And so I just wanted to make a note that although it can be shed through the stool, there has been no information to date that anyone has become sick with COVID because of direct exposure to treated or untreated waste. This one, just the advantages, I just wanted to point out that the advantages is just another method for earlier detection. It has the ability to test for symptomatic and asymptomatic carriage. So those people that are maybe not going in to see their doctor, we might be able to capture them in this area. 80% of most U.S. households are served by some sort of municipal sewage system. And then one of the bigger advantages is we are really trying to see if it can be a leading indicator to increases being seen in the community. Again, another note, it's not possible at this point in time to really reliably and accurately predict the number of infected individuals in the community based on sewage sampling. But it does allow us to monitor trends and watch for those in correlation to what's being done. The areas where we started, this is the trend we're seeing from sampling being done in the Bismarck region. As you can see, kind of cases go up, the number of samples is going up. Again, much of this is being done. They're still learning This work is being done through NDSU collaboration with their sample and the Department of Environmental Quality through that through their program. And then the health department was brought on because we wanted to see how well it's correlating, these sample collections are correlating with the data that's actually being collected through the sampling technique with the sewage or the wastewater. One of the things, like I said, we're really looking, they were very excited. The Fargo data kind of bounces all over a little bit, but the one thing that they kind of noted was, we see a few peaks and then a few days later, we start seeing a larger number of cases. Again, around the 28th, we see a peak, and then a few days later, we start seeing an increase in cases here on the 7th. And the one thing I should note is some of the differences that we may be seeing between the different communities at this point in time is because the lab is in Fargo and the people working on the project are in Fargo, it's a lot easier to collect Fargo samples. So we are typically getting about 4 samples a week from the Fargo area versus Grand Forks and Bismarck. They're down to anywhere from 2 to 3. So the fewer samples you get, you might not see as much variation in theirs. The Grand Forks data, as you can see, it kind of was all over. Like I said, still learning how to work the system, how to do the lab results, how to do the testing, but they continue, and there's been a bit of a lag there on the actual collection of those samples. The plan is to additionally move to other semi-larger communities such as Mandan, Williston, possibly Jamestown, doing some select areas such as maybe hospitals, state penitentiaries, where their sample collection would be specific to that population, as well as doing some of the smaller communities that are out and about that don't really have access to some of the larger testing events. And this will be especially notable in areas maybe during the winter where these auto samplers can grab data that it might be harder for people to get in. It's, again, just kind of an additional piece of information that we can utilize to monitor the trends of COVID infection among communities.
Tracy?
Yes.
Hey, one of the things that I've seen in terms of the wastewater use is at some of the larger universities are actually doing it on an individual dorm basis. So they know when to basically start testing throughout a dorm to get more specific positivity rates and then deal with those clusters before they become community throughout the university.
Yes, and that is correct. I believe that we are considering that. Another thing we are also looking at is, do we look for like manhole areas that are just, that basically are just leaving outside of, say, Greek housing. So it's not only just the dorm specifically, but how could we capture data that are looking at campus level data? So there's a lot of planning going in. We did meet with CDC a few weeks back about, because this is really new nationwide. We've done it for polio and they've done it for a few other items, but it's certainly new to COVID. And so there's not, as with everything related to COVID, the knowledge base is still kind of ongoing as we learn new things. And so we are looking at some of those types of areas as well, including the dormitories.
Seems like a very good potentially targeting tool that gets ahead of the worst of the spread.
Yep, that's what we're really hoping to see, is even if you can only get, 2 days before we start seeing increases, that would be enough time to be working with Nikki on getting maybe testing out there, or identifying areas where maybe we need to start doing a little bit more education on masking and social distancing and quarantining and isolating and things like that.
So I will tell you that this is for you and Grace both. Thank you very much. This is probably the most informative presentation that I've seen individually, either as a citizen of North Dakota or as a council member. The only communications we've been getting really are your public announcements at this point. And I think this is going to resonate very well, I think, with several of the more scientific minds on this body.
Thank you.
Questions for Tracy or Grace? I have one, Tracy or Grace. The analyses that you've been doing, have there been any sort of approaches developing simulations for strategy effectiveness based upon the data that you're developing now, so that you could seed models in terms of, hey, if we take these specific actions, here's what we would expect to see as a health response?
I would say that's actually built into the RTs when you think about it, because so for example, if you're examining this by, as a statewide level or even at the local level with counties, you can usually see where changes were made, say in like policy, and what the effect that had on the RT value. And so we have not had time to, retrospectively go back and just look at, every single county or, overall, but the general trend does kind of like show you what are some critical things that happened that had an effect in terms of changing the trajectory of the RT value.
Are there any actions that have had significant response or that stick out that you think are valuable that the community should know or have demonstrable benefit?
I don't know if Dirk, you want to speak to that. I can't think of anything, but I think when you look at the trend, say with the policies back in March, you do see that decline in the RT value happening.
Okay. Thank you.
The only other thing I would add is I know that kind of as we move forward, we are going to be trying to include into the contact tracing. Kirby can probably speak to this a little better as well. As we kind of move forward with some of this, looking at, the mask wearing and some of those things, we are also looking at what are some of the issues that maybe we can try to tease out of the data as we go to do kind of that very thing to see how much of a difference can we make and what information can we be, with all the information that we currently collect, how much, what is reasonable to collect more? And how can we utilize that for instance, Grace's RT model?
Are we collecting any information on basically voluntary community masking, that sort of thing, so that we can hopefully later attach it to those sort of correlative models and begin to understand better what the impact actually is?
I believe if Nicole Pesky is on, she can speak to that.
I don't see her on, no.
And I know Kirby.
There are some more recent estimates that she's been working on.
So maybe we can circle back and get that information to the council.
Yes.
Thank you. Other questions for the staff with regard to data and data analysis, how it is informing strategies? All right, I'll ask another question that came from the outside world a couple of times in the last several weeks, and that's on the, and I think the governor partially addressed this in one of his presentations, but it's clarifying the bed and bed capacity issues. I think the question really relates more to ICU availability as opposed to number of beds and maybe ICU occupancy rates. Can you explain that data and how it's presented to the public, and maybe if there are changes in that data and what it really means in terms of the medical community reaching out and saying that they're worried about their capacity and their staffing limits to serve every bed?
And I'll actually throw this one over to Tim, if you'd like to respond to that question.
So I'm wondering if I can respond to more generally to set some platform first, and then Dwayne try and come back. and more specifically answer your question. Dirk, is that acceptable to you as well?
Well, whatever is acceptable to the council.
Okay. Well, so let me just talk a little bit, because it does directly relate to the whole notion about staffing and some of the issues in terms of what the department's doing and what the hospital plans are. In addition to the missions that you just heard talked about in terms of the laboratory and contact tracing and so forth, there are other missions that are occurring in terms of trying to find additional staff within the state. First of all, I want to talk about two main areas. One is the Medical Reserve Corps, roughly about 1,400 medical professionals that raised their hand and said during an emergency, send me, mostly physicians, nurses, and EMS personnel. This is kind of a snapshot that's done at the time of a need. We can typically garner on a normal day between 30 and 40 people quickly out of that mechanism if we don't have any lead time. So that's one of the sources that we're driving additional staff from. But the one I wanted to mainly talk about is the fact that there's been a temporary staffing to build up additional staff within the health department to assist with some of the staffing needs Dwayne that you were just referring to. And so normally we have within the section that I lead a little less than 60 folks, but that's carrying out all of the normal program functions, and about less than 10 folks are engaged in the actual emergency response. This is the staffing pattern as of yesterday that we've brought on 39 full-time RNs and 79 part-time for a total of 118. You can see that split out. We've got 38 total LPNs, 46 EMS providers, 28 couriers that are delivering various mechanisms, 16 CNAs, 8 emergency CNAs. This is an abbreviated course for developing additional CNAs, and then 10 that fit in the others. So we've brought on about 262 staff to assist with various missions. And now I want to talk about just quickly the 5 major components that staff is investing its time in. One of those is the operation of our Department Operations Center. So that's the command and control function that requires the staffing. It's available 24 hours a day, 7 days a week to basically coordinate and move through with the missions. The second is to assist local public health with their response tasks. So here we see a local public health unit that's being supported by state resources, including health department personnel that are temporary employees of ours, to assist with specimen collection. But there are a wide variety of other local public health tasks to supplement that workforce. The third are state-level testing processes that are being done to directly participate in it. And then Dwayne, directly to the point that you're talking about, and that's filling medical staffing gaps. And those are right now primarily occurring in long-term care because of the outbreaks that are occurring within long-term care, and the need to then furlough those healthcare workers that become infected and replace them with staff, and also to a lesser extent so far, but hospitals are part of that gapping. Or the gaps that need to be filled as well, and so that is in fact that fourth mission. The final mission is the state medical cache, where medical supplies, both durable and disposable medical supplies and pharmaceuticals, are distributed to the hospitals, long-term care facilities, and a wide variety of other medical and public health response entities. So, just to give you a real quick idea in terms of where these investments are being made, these are the staffing events where health department staff, these temporary staff, where their time is being invested. So far, in terms of testing, 146 testing events last week were conducted in long-term care. That's larger than all of the other categories of testing combined for the staff investments. And there's also the courier missions that have been involved in moving specimens back and forth, whether that's personal protection equipment or the movement of various testing supplies. And then finally, in terms of the warehouse, the number of orders that are placed for this past week, just to give you an example, for either PPE or school masks that were deployed and other types of activities. So now, more directly to the question, and that is, let me just get my screen back here. And that is, we have 3 tiers that we move through, and at this point, the hospitals have been managing substantially without having moved through those tier levels. Although the planning assumption has been from the beginning that we would move the entire hospital as a complete system, so that we'd be transferring between hospitals before we start to do other more drastic measures like lowering standards of care, either by increasing the patient to staffing ratios or other techniques like that. Gathering a snapshot from yesterday, for example, we showed that we still had 236 general beds available in the data that was submitted to us for yesterday, and 19 ICU beds were still available. Now, that's just a snapshot in time. And while individual communities may have 1 or 2 or very, very critical shortages in terms of specific community, the idea is until we saturate the entire system, that we would not begin to take more drastic measures in terms of moving through these tiers. Last April, there was a planning process in which the hospitals basically did an estimate about the tier levels and what their capacities were between clear blue sky operations and then what they could potentially surge to as we move through this. And that process is being looked at right now, once again, to get a more accurate estimate in terms of where those surge capacities are existing. So I would expect in the very near future that we'll either confirm the numbers that we had last April in terms of the tiers, or revise those numbers. What I can't do right now, Dwayne, to be really blunt, is express in terms of a percentage to say here's the maximum number, here's the numbers consumed. What I can tell you is that we're getting daily reports from the hospitals in terms of the number of ICU beds and their availability, and then the other general population beds like med surge and their availability.
Yeah. I can say that in the last couple of weeks, I've gotten a couple of calls. This last week, I've had 3 calls from family members saying that their individual family member is just waiting in the emergency room until an ICU bed will become available, in all likelihood, days from that point. And that's somewhat disconcerting that you're hearing reports from one end saying that, and then from the health department's perspective saying we have a couple hundred beds available.
So I'm not aware, at least, I'm not aware that there are people waiting days in an emergency department setting. That would be news. It is not unusual, though, in order to facilitate these transfers throughout the entire system, to be spending many hours, and so that would be.
And I recognize there's the option for these people to relocate to another hospital away from where they are and get to a room right away. But for family reasons, they were very upset that they didn't want their family member to be 100 miles away or 200 miles away, and so they made the choice to wait for a room.
Yeah, I can certainly understand that. I know that the information that we have is that the hospitals are maximizing their capacity, but again, to be clear, that the next steps that would be taken in terms of the state plan and the tools that would be in our arsenal would be to create additional bed space by lowering standards of care, which I think, I haven't heard anybody support that approach. So what's being attempted now is to continue to move throughout the state as a complete system. I realize there's huge inconveniences and implications of those transfer costs and all that goes with that. But there's also a lot of effort being put into to find additional staff, but it's difficult to find additional staff, and so there are very difficult choices being made right now.
Yeah. So I'm just bringing that up just because that's one of those data points that I think somehow needs to be refined so that sort of the information you're hearing from two different ends starts to come together. I'm not sure how we address that. I know that there's a new reporting requirement that you're working with now as opposed to the old one, and maybe that will improve it.
Yeah, and again, I just to reiterate that through the Hospital Association and our collaboration there, this is being looked at in terms of revising the numbers. Is it possible for us to express this differently to get a clearer picture and to reassess what those capacities are? So from my perspective, the best information that we have right now is profiling this as a system, but then completely acknowledging hospitals are under stress in some communities. The hospital capacity is getting filled on a routine basis, especially in larger communities, because hospitalization rates are up, not just for COVID, but for trauma and medical emergencies such as cardiac issues. And so this is a difficult situation.
Yeah, and I know you have a difficult situation in getting the data as well and getting it in a format that helps meet all of your needs, but I know that you're working really hard on that and we appreciate it. Are there other questions over data, data analyses, data that this commission would like to see communicated to them?
I have a question. This is for
comment if I could, and that's only to say that I appreciate the work that Tim and the staff have done in order to make that data regarding hospital bed availability more accurate by defining what facilities should report. And of course, it's only a snapshot at that particular point in time, and it does change because smaller facilities that are trying to transfer patients to our a higher level of care are having challenges with those patient transfers, and sometimes patients need to go great distance. But I think the health department is doing a good job, and again, thank you, Tim, and your staff for trying to provide an accurate snapshot of what's available where.
Tyler, were you going to say something? Is that you?
Well, I was going to say something. I got to take off, guys. I got a meeting with NDSU, but thank you for the meeting today. It's been insightful. I appreciate everybody's comments that joined. I'll follow up on the minutes when they get out to us. And so thank you very much.
Thank you, Tyler. And so I guess that brings us down, I think, to Department of Health and Communications with the State Health Council. There have been several comments by members of this council in terms of feeling like they were a little bit out of the loop and felt like they should be more in the loop with a current crisis going on. And I know that communications management from a crisis when you're the ones actually on fire dealing with it is relatively difficult, thinking about all the audiences that seem to want to demand your time or your attention. So I would kind of open up to the council to please, I mean, this is your opportunity to be heard in terms of what it is your expectations are in terms of communications from the department.
Chairman Poole, and I know we've shared some of this in the beginning, but really when I look at the diverse group of people we have on this council, I think that there is a lot of expertise in many different areas that we would be able to maybe be of assistance to the health department. And it's difficult for us to know where our role is or how we can assist when we're not knowing other than the public release information on deaths and active cases. I personally, from me being on the Health Council, I feel ill-prepared as far as information of what's going on, and I'm finding out more of it from the Fargo Forum or Bismarck Tribune and what's going on, rather than actually hearing it from the source. So maybe it's not so much as a matter of taking direction always from the Health Council, but really being able to use this as a resource. And I think Nguyen has tried, at least I know, to the governor's office, but maybe also reiterating that to you, Dirk, as well as the staff, that we are here to help and we really do want to be a resource for you. And if there are challenges that you're having or even updates that are going to be pushed out to the public, it would be helpful for us to know that, because we do field calls. I know Dwayne's gotten phone calls. I've been reached out, as well as I'm sure other Health Council members. And it's better for us to be prepared rather than ill prepared when those things come our way. Thank you.
This is Jim. I was going to make pretty much the same comment there, that I think we should be asking what we can do to be of assistance in this pandemic. But like many of the others, I do feel like we've been left out of the loop, even in this state strategic health plan that's being developed. Seems like somebody from the State Health Council should have been on that, involved in that process. But I just sort of feel like the State Health Council has been forgotten. And if we do have a role to play, I think it has to be defined or redefined by the governor so we know where we stand. One more thing I'd like to add too is that we've had a couple of comments, one from Dr. McDonough, the one from Senator Mathern, and there were a couple of others, I think, too, that sent inquiries that were shared with members of the council. And I think they should receive some kind of a response from us, either now or after our next meeting, I guess, as to some of the specifics that they brought up in their requests. Probably Dwayne contributed, I think.
I wholeheartedly agree with Dr. Brousseau's comment in that regard, that we don't want that communication we receive for that sender to feel like it's fallen on deaf ears. And I guess I'm curious as well how the health department, or Dirk, how you would plan on helping or develop a response to the requests and the comments that were made.
In terms of the response that are made from the outside entities, I'd have to relook at those. I know that a lot of them circulated about mask wearing, and there was some comments about the Department of Health may be presenting an inaccurate view on our stance on masks. To me, we're pretty clear. Masks are effective. Masks are helpful. It's always been part of our communication and our strategy. I think there's always been the ask of a mask mandate, right? And so if the conversation is why am I as state health officer not doing a mask mandate, I think that's covered numerous times by the governor. While we believe masks work, we're not sure mandates do. The reality is half the states that have mask mandates are also in the top percentages. So I can't remember where I heard the phrase of how vaccines save lives. So having a vaccine doesn't save a life. Having somebody take a vaccine saves a life. And so we have to make sure that the people are wanting to do it. We have to make sure that they're wanting to take it. And we can't just order and demand that they do. And so I think that's sort of been the stance and the strategy all along, is to make sure that these decisions are happening on the local level and the personal level. I support that idea, but to be clear, we want masking. We changed our close contact order to incentivize it. We have an ND Mask Up campaign. We believe masking works. And so I know that was kind of the bulk of a focus of one of those narratives. In terms of the other one, it was really targeted about the State Health Council's role and what you should direct us to do as a Department of Health. I would be happy to work with Dwayne on a response to that. But I think what I'm hearing. Go ahead, Tara. I think
I guess some of my concern as well, though, is that I don't want you to put the Department of Health in a position where they feel the need that they have to respond to every single criticism or every single piece of information that they receive from the public, because then they would essentially spend all of their time responding to these comments and not focused on public health. And so I also want to make sure that we're not giving individuals a greater voice because they're a legislator or because they have friends on this committee, and that, you know, that causes me some concern.
Thank you, Tara. I appreciate that. Dirk, do you want to continue?
I would say just the message that I've heard loud and clear in the conversation is how can, instead of maybe of how you can direct us to do something, I think it is appropriate to say, how can we reach out to you to utilize your expertise? I mean, I know Dr. Brousseau has a long history of public health, and so it does make sense to reach out to him on some public health matters. And so I think that's advice well taken and pointed. There may be an avenue. Additionally, we do have a unified command meeting. I think it might be appropriate to see if we could loop a health council member on those calls, because I know we have constituents across local public health and other avenues where maybe a member from the health council might want to participate in those meetings and calls to ensure that you guys have the information that's presented on a weekly basis. So there, I do see avenues to help navigate maybe the communication issue that's happens before, and I'd be more than happy to work through that with you.
Yeah, and I will say this about the letters that we got from the various medical groups, that they're completely lucid. They are science-based. They're fact-based. They're based off of very well accepted literature and understanding of disease and disease spread in many of their items they'd like to see. And I think hopefully that medical advisory committee that provides advice to you echoes very strongly the best medical advice available to you. And I couldn't imagine that they wouldn't do that.
Jim here, one more comment. I think the governor and the health department have gotten plenty of messages from physicians and so forth around the state as to what they feel about masks and so forth. And we don't need to pile on by adding the same recommendation for a mask mandate. But, you know, one of the things that Dr. McDonough suggested that I thought was good was to do to monitor mask use, or to somehow survey mask use around the state. I don't know if that's feasible or not, but it may be something that the health department could look into to see if that's being done. I thought that was a good suggestion.
Yeah, I know that we are doing surveys across the state on a variety of topics, including, but not limited to, obviously, how trustworthy the health department is, how effective contact tracing is, so different aspects of our response, and so that potentially could be included into that mix and survey. So I think that's an idea to reach out and see if we could include that.
And then I would toss this out to your epidemiologists and others, and that is one of the concerns that's been fairly consistent from the more local units that have contacted me has been over the concept of people that handle food or drink not wearing masks and the spread from that perspective, and whether or not there are very specific, more targeted responses that could be generated that would have a huge benefit to public health, but a very small cost in terms of number of people, level of sort of inconvenience in asking them to use better infection control.
And I hear that. I would say that we do have a very strong leader in our food and lodging department who actually used to be an epi, and Julie Wagendorf, and she has created some similar documents and has reached out pretty actively to the food industry and the restaurant industry on those various topics. But it might be we might want to circle back with the color changes recently to reemphasize that point.
I would at some level expect that within the color changes that there be actual targeted interventions. I would like to see the next time you discuss what mitigation measures are within colors and color charts, that those high value targets be identified as.
And I would say that they are.
And then the one other thing that I would add in is that in some of the data that's supplied to the Health Council, what some of the stuff that we saw today from the EPI group resonates really well with me, but I admit that I'm a biometrician, I'm a data nerd. So I would ask the rest of the council, are there specific elements that you want to see communicated to you on some basis, and what would that basis be? I mean, weekly, 2 weeks, monthly?
I would say sometimes put a date or time on it, Dwayne, just depending on how it seems things are quickly changing. So it's difficult to say we want it every 2 weeks or once a month in that regard. But I think if there's major changes in how processes are being done, or like as you referred to the color wheel, looking at orange, do we want to, is the Health Council looking at maybe adding more levels of accountability for businesses or whatever the case may be? I think those types of information bullets would be good for us to know. To be able to put a timeline on that, that's hard to say. I just, do we need to know every little thing that's going on in the health department? No, we do not. But if it's maybe that higher level, like the wheel chart, which the entire state understands and knows, and if you're adding different levels of what expectations are for that, for businesses or the like, I think that would be good information for us to know as an example.
I think that's a very good suggestion. And I also want to commend Dwayne for his good work as chairman of this council. And I think if you just send out not directives, but communications to the people on the council when you think there's something we should know about, I'd be satisfied with that, rather than a weekly or a monthly report.
Was that me or was
I agree that we could probably use some more data than what we get, but we don't need, like Jenny said, we don't need a daily update of exactly what they're doing. But like the slides and the data that were shown to us today were very helpful. That when there's kind of big change items, that would be nice to see.
The only thing that I would caution you about when we're talking about discussing and sending emails is that remember that this is a public body and it has to do with its business in an open meeting. And so to the extent that there are emails, they cannot include a reply all where there would be an email through, or kind of a meeting through the email mechanism.
Yeah, and that's, and I would go back to two things. One, I think that Jenny was hinting at is that development of products specifically for us, we think is probably unnecessary. Sharing of products that would be informative that are already a part of your regular work product is, I think, more of what I've been hearing from my council membership over the last several months.
Yeah, I think that those are reasonable requests.
Maybe we could also just, if the spirit moves us, we could just send a little synopsis of some of our thoughts to Dwayne after the meeting is over today, and he could have a written record of what we said and think.
To what end? So that it just sits on my desk and I read it, or now that then becomes, okay, well, if you send those responses to me, what specific actions or directions does this council have that they want me to follow through on?
Personally, I think it would be important if we can really get a sense unless Dirk can tell us what the governor wants from us. You know, Dwayne, you've reached out to the governor's office inviting there to be input and or participating in this meeting. And there hasn't seemed to be that interest. I guess I'm curious as well from that office perspective, what additional information and insight can we bring to help him do his job?
I would add to that I would, Kristen, can you provide that perspective from the Legislative Health Committee too? I mean, I'm expecting.
Yeah, I would say that we don't really have that from there either. So I don't know that I have any additional direction to help us with that. I think that's been one of the challenges from all those directions.
So basically we can do whatever the heck we want. There are no expectations. No, that's not what Tara said. She said something else. Well, I really appreciate everybody's participation today and you guys asking to have this. It was very informative for me as well. I especially want to thank the staff who helped put this together and provide the information for us. I feel as a public forum, since this was viewable by the public as well, I'm hoping it was incredibly informative to them and the public or other stakeholders that have a very stark interest in this particular issue and what the role of the Health Council could or is in this process. Hopefully it's answered a lot of questions for a lot of people. Still leaves a few questions remaining to be answered. But I think Dirk fully understands the questions and the struggles that we have in terms of trying to fulfill our role. And if there's a role, none of us want to drop the ball on it and not do our job. But at the same time, none of us want to overstep our authorities or bounds and stick our nose into everybody else's work product that they're trying to just diligently get done and focus on the task at hand. Are there any other closing comments or requests from the council members?
Only to say that I echo your comments, Dwayne, and appreciate all the work that staff does. It's a tireless job, and we appreciate all the hours and efforts that you guys have all put forward. So thanks.
All I would add was I feel like everybody on the council would agree that we would, whatever role they would like us to have, we would just like to be asked or like to be wanted to be involved. I mean, any of us, I think, would be as active as they would allow us to be or they'd like us to be, but we don't want to impose onto other staff also.
I'll say this, and it's been consistent amongst the board members that have spoken with me over the last 9 months in various cases after various meetings. Every single one of us are on this board not to put a line item on a resume, it's to serve. And I think that's the message that, Dirk, when you do talk to the governor's office, that's the context in which I would express that, is that we're not afraid of work or we wouldn't have taken the position. It's not a resume filler.
Yeah, and I hear you, and I'll say that at least from my standpoint, I do appreciate the work and the commitment you put into it. I know how hard you how many emails you guys get. I know how much pressure you get that may be unnoticed and unwanted. So I do appreciate you navigating those waters and communicating to the health department.
All right. I guess we'll conclude this special meeting of the State Health Council without objection. All right.
I will move to adjourn.
We are adjourned. And as I said before, feel free to reach out to Dirk or members of the council. Don't let it be a conduit or an impediment to you guys feeling like you've got input or that you get response.
Absolutely.
Okay, good meeting. Thanks a lot.
Thank you, everyone.
Thanks, Dwayne.
Thank you.